and I'm been working on antimicrobial stewardship in the Children's Hospital and also with the BNSSG for a few years now. And the reason we are so hot on antimicrobial stewardship is because antimicrobial resistance is a big problem, and it is predicted that in the next 20 years we'll have more death than cancer. So the reason why antimicrobial resistance happen is because we are using antibiotics quite a lot, and we don't have very many new antibiotics in the pipeline. And as you can see, resistance happens at a faster and faster pace because we are using more and more of these antibiotics. Doctors are a big part of the problem, but not only antibiotics are not only used in human medicine, and so what we're going to focusing on today is really just the human part and what we can improve.
Sorry to interrupt, Stefania. Is it possible to move the mic any closer to yourself? It's a little bit muffled.
Oh, sorry. We'll try to.
Thanks.
Can you hear me better?
Yeah, that's much clearer. Yeah. Thanks.
Okay. So our big ally has been vaccines. So vaccines have been very successful in reducing bacterial infections. And in fact, from the 90s, we've had more and more of the bacterial vaccine that came into the routine schedule with meningococcus and pneumococcus. And for each vaccine that has been introduced, we have seen that disease disappearing pretty much. So that happened with Hib, and you can see that there was a little bit of a peak a few years after the vaccine was introduced, and then the schedule was improved, and now we don't see really Hib. Similarly with meningococcus, and I see some pneumococcus still because the vaccine doesn't cover all of the serotypes. But the consequences of this very successful vaccine is that we do not see a lot of bacterial infections anymore in children. They're pretty much gone. And in fact, the bacteremia rate in these are hospitalized children with diagnosis of serious bacterial infection. The bacteremia rate is less than 1%. And several studies in different parts of the world have shown the same number, including the UK. And even with community-acquired pneumonia, only about 12% of the children admitted tend to have bacterial infection. All the others will have viral infection. So vaccines have been very, very successful. But we still prescribe a lot of antibiotics. This is a nice pediatric picture that shows you the European prescribing habit, and we see that Greece is a big prescriber, Estonia is a very good prescriber, and the UK is kind of in the middle. So we have quite a lot of room for improvement. And what is really important is that actually the amount of antibiotic is not linked to under 5 or under 19 mortality. And you can see that Estonia, who was prescribing very little antibiotic, has a much better mortality rate than Greece, that is a huge prescriber of antibiotics. The UK has got a high mortality in under 5 and in under 18, but this is a different story. Definitely is not linked to how much we prescribe. The other thing to say about antibiotics is that amongst the medication that are prescribed in primary care, antimicrobials are the ones that have the highest risk of harm. This is probably because it's the medication that is prescribed most commonly. And the risk of harm goes from prescription of the wrong dose, so overdosing, underdosing, side effects, etc. So it's something we do a lot, and it does have harm, might not be useful all the time. Plus, there are quite a lot of side effects, and adults, as you know, are at risk of CVCPL, children much less so. However, diarrhea is a big issue, and diarrhea often is associated with nappy rash for the little ones under 2, and nappy rash are a problem for the family, for the child, and then sometimes they require other treatments. in very little children, neck is a problem, and there is increasing body of literature that shows that antibiotics, particularly early in life, are associated with chronic diseases such as atopy, diabetes, obesity, etc. So these are data that Louise Jonas gave me, and they are very readily available in the EduForum website, and just show the extent of the use of antibiotics in children in the UK. And it looks like about 50% of children under 4 are prescribed an antibiotics when they come for consultation. So it's a huge amount of antibiotics. And this is a very nice slide for the BNSSG. These are the antimicrobial use in children in the UK, and it compares all the regions of the country. And you can see that the BNSSG is the darker blue at the left-hand side, which means that we are the lowest prescriber group in the country, which is really, really good. Here you have the data from the BNSSG only, and you can see that there is variation within the region. So although we do very well nationally, we still have a lot of work to do to make sure that this variation in practices kind of reduces, and also a lot of work in trying to establish why some practices are prescribing so much. This shows the trend of prescribing in pediatrics, and you can see that during the pandemic, so 2020 until mid of 2021, prescribing was very, very minimal. As you know, nobody was coming out, nobody was having any fevers or anything. And then we have a big peak at the end of 2022 when there was the outbreak of group A threat. But the sad story is that we still have this seasonal variation, but there is a kind of a trend going up. So prescribing has not gone back down to what it was pre-COVID. I would like to kind of share with you this very, very nice communication posters that are available in the website in there. These are produced by the University of Oxford, and they're very, very much used in the BNSSG. And they just help with infographic to kind of talk to the parents and put them in your waiting room to explain to people why they might not get antibiotics and what the expectation should be. This again is just again really similar to the one before, to try and show that these information help driving the work and help us understanding why certain practices prescribe more, looking at inequalities, looking at population and so on. I just wanted to make this a bit more clinical. Just think about a case of child with tonsillitis, a 36-month-old boy who has a temperature for a couple of days. What would you do? If you just do the poll that appears in your chat, I think, and start voting, it would be amazing. Thank you very much.
I think it's under the Slido tab, isn't it? If people haven't seen that.
It should also show up in your chat, I'm hoping.
Oh,
so I kind
okay.
of popped something up in your chat, and as if I sent a message. So hopefully you can see that. Please let me know if you can't.
Yeah, I think that links to the Slido thing. So that's great. Thank you, Kira.
I can't see it though. Just a second. I try to minimize the sorry, maybe I cut this because otherwise we're just wasting time. So I would guess that a lot of people would be sitting on the fence on this one. Maybe.
So
would
the
be-
results are that 100% of people have said that they would consider giving a delayed prescription in case that it does.
Amazing, amazing. That would have been my choice too. So we all agree. So why parents come to a consultation? Very often there is not the hidden agenda of wanting antibiotics. Can you see the slide again? Or
We can just see your screen, Steffi, but not the slides. So I think when you came out of that, the slideshow didn't come back again. There we go.
can you see it now?
Yeah, it's not, that's it, it's
Fantastic.
in slideshow format now.
Okay, perfect. So often patients just really want to be reassured. So they do not have a hidden agenda. They just want an expert professional to tell them whether their child will be fine as it is. They have to just be a bit more patient, or the child needs some more treatment. There are a lot of very helpful leaflets that are available, and sometimes it's quite helpful to give in consultation those leaflets. And there are also now very good apps, like the Handy app, that the parents can look at. And, it gives them an idea of when they should worry. And they also give them an idea of how long all of these viral infection lasts. And many of them last a lot longer than people expect. And in fact, it's much more likely that the child is more severely sick if the infection has not gone on for very long. And this is a nice slide that shows you that actually the duration of symptoms doesn't really change whether you give antibiotics or not. So, antibiotics are not always the answer. And the reason why we prescribe antibiotics often is just really because we are really worried that we might be wrong in diagnosing and we might miss a bacterial infection. And what is really important to also think about is that human race continued even before the antibiotic were ever existed. So actually, if we miss a bacterial infection, the chances are the bacterial infection will be killed off by our fantastic immune system. Very few patients will become very sick. So, we don't have to think that we need to know whether an infection is viral or bacterial. What we really need to assess is whether an infection is severe or not. And in fact, a lot of viral infection will need hospitalization, like RSV, but not antibiotics. And again, one of the facts that often people don't know is the fact that actually the risk for tonsillitis of developing a quinsy is much higher for older children rather than small children, which is what often we don't think. We tend to think that the little ones are much more vulnerable. And if you are trying to prevent this complication, the number that you have to treat is actually quite huge. And within the BNSSG, I'm sure you're using the fever pain tool, and there is also the Target leaflet. And Target is a very good website. I forgot to put the QR code that has a lot of information on antibiotic use, courses, webinars, etc. Otitis media, I've not done voting on this one, but basically, I'm pretty sure we all think that this child will need antibiotics. Again, it's a bilateral otitis media with very high fever in a young child. Here, very similar data as from before. If you are treating with antibiotics or not, unilateral otitis media that is not particularly severe, the duration of symptoms is actually pretty much the same. And your number needed to treat to avoid a mastoiditis is even bigger than with tonsillitis. And again, the older children are more at risk. And I guess you will use the antibiotic audit for acute otitis media. Here is a child with cough, and again, I hope that we all believe we do not necessarily need to treat this child with antibiotics. A lot of these children will have viral infection, and in fact, a lot of the hospital admitted children have viral infection up to about 80%. These are the children that need hospitalization because might need oxygen, might need NG feeding, but actually don't have a bacterial infection. Again, this is a very helpful leaflet, was developed in Bristol by one of the groups that is very active in helping this message to go across and helping the parents understanding how to best care for their children. And I'm pretty sure you are all aware of the prescribing guides in the BNSSG, and the pediatric prescribing is all in yellow to make it very relevant. And we've been using the weight for prescribing, and I wonder whether you prescribe according to weight or according to age band. And maybe if you can see the slider, if you just tell me what the result is. Yeah, what is the split?
So the votes are just coming in now. We've had, oh, they are very split, actually.
Oh, okay.
So the majority say generally no, but then it is 50-50 between the other two, which are mostly and only, apologies, that's a baby in the background, only if the PX is that the is in the practice or if I have their weight handy. So the majority are saying generally no, but it is very split.
Fantastic, because we are trying to introduce weight, because it's very well studied, the fact that if antibiotics are prescribed according to age bands, they are underdosed because the weights are they are too conservative, really. And what we were trying to do to improve prescribing is to do an audit and looking at who's using weight bands, who's using the BNF, and what are the barriers. And please do contact me or Liz if you're interested in participating. Another thing I wanted to say is that there are a lot of new studies coming up looking at equivalence of shorter versus longer antibiotic courses. And the big message is that shorter is better. You can treat community-acquired pneumonia with 3 days, and it's no different from 7 days. And quite a lot of new studies in that are happening. These are the CAPIT, which was comparing 3 days versus 7 days for community-acquired pneumonia, and SCOUT in the US was comparing 5 days, I think, to 10 days. And both of them came saying that the shorter was as good as the longer. So there is a big shift into try to shorten the courses. Within the BNSSG, again, there is a big drive into that, and there's very successful stories, actually. And I just wanted to give a few pediatric tools available. This is the BSAC, which is the British Society for Antimicrobial Chemotherapy, that hosts the pediatric page. And in the pediatric page, there are webinars in the Pediatric AMS forum that are happening every third Wednesday at 5 o'clock and talk about pediatric antimicrobial stewardship. And then there are pediatric pathways that are very relevant in primary care and in ED, and they just show common infections such as cellulitis, UTIs, and how to separate more severe, less severe, antibiotics, and so on. And then there is the antimicrobial group guide that's mostly secondary care, but it's very useful in primary care as well. And the BNSSG guide is very similar to that. We're trying to align all the pediatric prescribing. The other thing about pediatric prescribing is the palatability of what we are prescribing. So the idea would be to prescribe as little as possible. But when you prescribe, you probably want the child to take the antibiotics you're giving. And to do that, short courses are better. And we know now that they are not inferior for the outcome, but they're also better for the child and the family because they will remember taking them. But if you have a medication that you have to give 4 times a day, consider that it might not be very good compliance. And also, if it tastes disgusting, the child is likely to spit it out. So choose something that might be less narrow spectrum, but is more palatable so that your child will take it. And also think about the pill school. There is a very good website with a lot of information about how to help children to swallow pills. And again, adherence is much better if we give antibiotics less frequently because we all remember them and remember to give the correct dose and weight is much better than 8 pounds. Finally, a lot of children are labeled as penicillin allergic, and we know that about 90% of the penicillin allergy label is wrong. About 90% of those are actually not through penicillin allergy. And this is a very helpful website, part of Healthier Together, that talks about penicillin label and how to delabel and when to refer to allergy clinic or when to properly label as penicillin anaphylactic. And this is a really important work because these children keep this label all their life, and people that have penicillin allergy actually are much more likely to die from infection because the antibiotics we have that are not penicillin based actually are much worse outcome. And finally, this is my last couple of slides. I wanted to ask you if you were aware of the new remedy guideline on persistent bacterial bronchitis. This has been put together by one of my colleagues, and we were just not sure whether this went through the network. And this refers to children that are less than 6 years of age. They have a wet cough for more than 4 weeks that don't have any other diseases such as TB or pertussis. It's a wet cough, so it's not asthma. And then these children that have got this kind of diagnostic criteria are treated with prolonged courses of antibiotics, so it's 2 weeks, and then a review, and if unwell still, another 2 weeks. So I'm not sure whether you were aware of this. I think this came out in June, July.
It's about 50-50. So about 57% say no, and 43% are currently saying yes.
Fantastic. And yeah, this would be a question for you guys, which is if any of the secondary care clinicians have guidelines that need to go live in remedy, what is the best way of reaching you? So this is the end of my presentation, and the messages are that AMR is a major threat. Antibiotics are rarely indicated in children these days. We have fantastic vaccines, but when antibiotics are needed, particularly, for example, if you have a chicken pox that has developed a fever after 2 or 4 days of the rash, you want to give the right drug, you want to give the right dose, and wait sometimes is a bit more efforty, but it's better, and you want to make sure that the child swallow the formulation, and we don't need very long courses generally. Leaflets and parental information apps are really helpful because it's a matter of educating not just ourselves, but the public that often still have to believe that antibiotics are necessary. Remember, the short is better is coming up from more and more studies, and also make sure that if you see a penicillin allergy, you kind of look deeper, maybe get another appointment to look into it, and either refer for the label or for desensitization. And I think I finished. And here are my email address and Liz Donna's email address. If any of you would be interested in helping us doing an audit, pretty much we were thinking about asking pharmacy students to help us doing the audit itself, but it would be a matter of hosting this little project in your practice. Do let us know. And also, if you have any ideas of how we can kind of talk to each other when there are new guidelines, etc., coming up, do drop us an email. Very happy to chat. Thank you. And I stopped sharing because it looks like I'm talking to a computer.